I would like to thank the organizers for giving me the opportunity to reflect on the most important advances in the management of metastatic breast cancer from the last 12 months. In HER2-positive breast cancer, I would like to focus on the DESTINY-Breast03 trial, which compared T-DXd with T-DM1. I will also reflect on some of the new ADCs and TKIs that are emerging. In triple-negative breast cancer, I would like to focus on the first-line setting with immune therapy, where we have new overall survival data from KEYNOTE-355. I will also reflect on some of the data with new antibody-drug conjugates, sacituzumab, but also T-DXd and Dato-DXd. I will briefly refer to a new emerging therapeutic subgroup, HER2-low disease, and we'll finish with ER-positive disease, where we'll discuss the overall survival data in the first-line setting, but also some of the mutational profiles that are emerging in resistance to CDK4/6 inhibitors, and finally talk briefly about oral SERDs and other new agents that can modify endocrine resistance. If you start with HER2-positive breast cancer, the standard of care in the first-line metastatic setting for many years now has been dual HER2 blockade with trastuzumab and pertuzumab in combination with this taxane-based chemotherapy. There's an interesting study that was presented earlier this year at ASCO that challenged the paradigm of starting with chemotherapy in combination with HER2-targeted therapy, randomizing patients with ER-positive, HER2-positive metastatic breast cancer and a disease-free interval of at least 12 months to either endocrine therapy and trastuzumab or chemotherapy and trastuzumab. A shortcoming of this trial is very clear that it didn't use dual HER2 blockade. Nevertheless, the results are intriguing, showing no clear difference in progression-free and overall survival, and suggesting possibly a benefit in patients with longer disease-free interval. This certainly warrants further investigation. Possibly we should consider including CDK4/6 inhibitors in this setting, as we have already seen encouraging early phase data. When it comes to the second-line setting, T-DM1, the antibody-drug conjugate, has been a standard for quite some time now, with a PFS of around 9 months in the registrational studies. If you look at third and subsequent lines, it's generally a combination of chemotherapy with HER2-targeted agents, including antibodies or TKIs, usually providing a progression-free survival in the range of 3 to 6 months. We had data at San Antonio from another new TKI in the Phoebe trial, which randomized patients to capecitabine and pirotinib or lapatinib, patients who had received prior trastuzumab and taxane therapy in up to 2 lines, but most of them did not receive dual HER2-targeted therapy or T-DM1 pretreatment. Nevertheless, the activity is impressive, showing that pirotinib is superior in terms of progression-free survival to lapatinib, with a hazard ratio of 0.48 and an overall survival of 0.69. And we will have to discuss how this can be possibly incorporated in our treatment strategies. The most important change of the last 2 or 3 years in the management of pre-treated patients with HER2-positive breast cancer has been the introduction of the new antibody-drug conjugate trastuzumab deruxtecan, or T-DXd. As we've all learned in the last few years, is that antibody-drug conjugates can vary massively in terms of their structure, but also in terms of their activity. We are particularly looking at the different payloads, the drug-to-antibody ratio, the type of linker, but also whether there's evidence of a bystander effect. Bystander effect is particularly important when we look at T-DXd, and it's due to the payload, the active chemotherapy drug, which here is the topoisomerase 1 inhibitor, being released prior to the internalization of the drug, but also they're diffusing out of the cells again due to a high membrane permeability. And as you can imagine, this can increase the activity, especially if there's heterogeneous disease. T-DXd was evaluated in the DESTINY-Breast03 trial compared with T-DM1. This was a trial with HER2-positive metastatic breast cancer where patients received prior treatment with trastuzumab and taxanes, either for early or for metastatic breast cancer. They were allowed to have stable brain metastases. If you look at the patient population, half of the patients were ER positive, 20% of patients had brain metastases, 40% received the treatment as second line, 50% as third line. The majority of patients had prior pertuzumab therapy. Primary endpoint, progression-free survival. And if you look at the results as presented at ESMO, a substantial and impressive benefit of T-DXd over T-DM1 with a hazard ratio of 0.28. The median PFS as per investigator assessment was 25 months compared to 7 months with T-DM1. And the benefit is consistent across practically all subgroups, including hormone receptor status, prior pertuzumab therapy, prior lines of therapy, but also brain metastases. If you look at the secondary endpoints, overall survival, again, a clear separation of the curve, not yet, I should say, significant, but I would expect this to be significant at a further follow-up. And if you look at the response rates, again, we see superior efficacy, objective response rate 80% with T-DXd compared to 34% with T-DM1, 60% complete response, 1% of patients only show primary disease progression. If you look at the activity in patients with brain metastases, we see clearly that the benefit is comparable to the overall study population, hazard ratio 0.25, median PFS 15 months versus 3 months with T-DM1. And if you look at the intracranial responses, we see an objective response rate of 63% compared to 33% with T-DM1. How does this compare to the data we have seen with tucatinib in the HER2CLIMB study, which is obviously different in the patient population, but also in as much as it allowed patients not just with stable brain mets, but also with progressing and untreated brain metastases. If you look at patients with active brain metastases, we see an objective response rate of 47% with a PFS of 9.5 months. In patients with stable brain metastases, we see a progression-free survival of 13.9 months. So those data compare well with each other. That interesting additional analysis of the HER2CLIMB trial presented this year looked at patients who had first progression in the brain, which was treated locally, and they stayed on their systemic therapy. And we can see there's clear evidence that these patients benefit from further continuation of their systemic therapy. Looking at the safety profile of T-DM1 on the left and T-DXd on the right, there are subtle differences between those two compounds as expected. Slightly more alopecia with T-DXd, slightly more ALT, AST increase with T-DM1, slightly more fatigue and diarrhea, nausea with T-DXd, more thrombocytopenia with T-DM1, more neutropenia with T-DXd. So it really requires a subtle differential view and look at the different safety profiles when we compare those drugs. One of the key side effects that has been in discussion for T-DXd is the risk of ILD or pneumonitis. And the phase 3 trial, where there was very stringent criteria for detection and management of ILD, we saw 10.5% of patients experiencing ILD compared to 2% with T-DM1. But most of those events were grade 1 or 2. 2 events were grade 3. There were no grade 4 or 5 events. Other developments in HER2-positive breast cancer, for example, SIT9 a different antibody drug conjugate, as you can see with the characteristics on the right. And it was compared in the phase 3 TULIP trial in patients with at least 2 prior lines of therapy or T-DM1 for metastatic disease. Again, stable brain metastases were allowed. The drug was compared with treatment of physician's choice, which included HER2-targeted therapy. If you look at the primary progression-free survival, there was a benefit, hazard ratio 0.64 with a median PFS of 7 months, but no clear benefit in overall survival at this point in time. And looking at the safety profile, again, it is clear how different these ADCs are. SIT9 led to eye toxicity in nearly 80% of patients, which was grade 3 in 20% of patients, leading to discontinuation again in 20% of patients, something we need to focus on if this drug will be licensed and used in routine care. Where are we at the moment with HER2-positive breast cancer? This is the situation we had prior to DESTINY-Breast03. Standard of care, clearly TPH in the first-line setting, T-DM1 in the second-line setting, and then T-DXd in a third-line setting. Since the release of the DESTINY-Breast03 trial, I would challenge this and would say TPH remains the first-line option, but T-DXd should move forward a line and is now clearly a second-line treatment option. But we have to discuss what happens in the third-line setting and need to learn how those what those tumors look like, whether they still express HER2, what their mechanism of resistance is to T-DXd and to ADCs in general. We're also aware that T-DXd is currently being investigated in first-line phase 3 trials and looking at this second, third-line PFS of 25 months, which compares very favorably to the 18 months we saw in a first-line setting with TPH. It is conceivable that we will see superior efficacy in the first-line setting, but that will raise the question at what cost in terms of quality of life, but also what other treatment options are we using then in the second and third line setting. If you move to triple negative breast cancer, where we have seen impressive changes in the early disease management with the incorporation of immune therapy and PARP inhibitors, in the metastatic setting, the standard of care has been over the last couple of years immune therapy plus chemotherapy in PD-1 positive patients, otherwise chemotherapy or PARP inhibitors if patients have BRCA germline mutations. More recently, we had the introduction of sacituzumab as the first ADC in second and predominantly third line setting. If you look at the data released this year, it was important that we saw the long-awaited overall survival data from Keynote 355. There are two phase 3 studies that are positive in this first-line setting, Passion 130 and Keynote 355, both using chemotherapy and immune checkpoint inhibitor in a first-line setting, but different strategies. In Passion 130, only using nab-paclitaxel as an option, versus Keynote 355 provided with a choice between nab-paclitaxel, paclitaxel, or gem-carbo. Both studies also use different biomarker strategies. Nevertheless, the results are remarkably consistent, showing in PD-L1 positive patient with the respective definition a hazard ratio of 0.67 in Passion 130 or 0.73 in Keynote 355, highly significant, but no benefit in patients with a CPS of less than 10. If you look at who are the patients who benefit from immune therapy in metastatic breast cancer, it is important to look at the distribution of those different PD-L1 assays, because there's a lot of ongoing discussion. If you look at the CPS assay with a cutoff of 1, which was initially discussed but didn't prove to be beneficial as a cutoff for breast cancer, 80% of patients would have been PD-L1 positive. If you look at the SP142 assay with a cutoff of 1%, 40% are positive. And similarly, if you look at the CPS score of 10, which is the cutoff that has been established as showing a benefit from immune therapy, again, it's roughly 40% who are positive, but there's incomplete overlap between those two assays that show 40% of positivity. And we will have to discuss whether there's a role for doing both assays in routine clinical practice. Both assays clearly describe the population that benefits from immune therapy, as you can see in green, PD-L1 positive patients in each of those trials, and red, PD-L1 negative patients. And we did additional biomarker work to look at further characterizing those PD-L1 positive, but also PD-L1 negative patients in an attempt to possibly identify additional, possibly better biomarkers. One of the analyses focused on immune phenotypes and on molecular subtypes. And as you can see very clearly, in PD-L1 positive patients, all immune phenotypes are represented, but also all molecular subtypes are represented. Of course, we see an enrichment for inflamed tumor types in terms of the immune phenotype, but also the immune activated molecular subtype. But if you look at PD-L1 negative patients, it doesn't look too dissimilar. We have more patients with excluded immunity or immune deserts. We have more patients with suppressed immunity, but ultimately we see a representation of all immune and molecular subtypes. If you look at who are the patients who are PD-L1 positive across those subtypes, we can see very clearly that whichever subtype you choose, you will find a certain percentage of patients who are PD-L1 positive and therefore may and are likely to benefit from immune checkpoint inhibitors. And therefore, as of now, still PD-L1 remains the key selection criterion for patients for immune therapy in metastatic triple-negative breast cancer. We also looked at some of the gene expression profiles and other biomarkers in order to better characterize responders, but also patients who show resistance to immune checkpoint inhibitor. And I just want to highlight one of those factors because there's a possible therapeutic implication. And this is angiogenitis, which has shown now in triple-negative breast cancer, but also in other cancer types as being associated with resistance to immune therapy. And an encouraging phase 2 signal from a study at ASCO 2021 showed promising activity with a triplet combination, nab-paclitaxel, a checkpoint inhibitor, and a VEGF targeting drug, but of course this needs to be verified in a larger trial. We've also seen 2 studies being presented this year focusing on patients not just with PD-L1 positive tumors, but more importantly here with high tumor mutational burden based on the data we've seen across other subtypes. High TMB was defined with a cutoff of 9. And as we can see, both trials with pembrolizumab or nivolumab, ipilimumab, we saw a clear response rates of around 16 to 20% in this group of patients. It seems that the higher the mutational burden, the more increased the benefit is, with a cutoff of 14 here on the right side showing you most of the benefit. But what is interesting, we see responses in patients who are otherwise PD-L1 negative, but also responses in patients who are ER positive. So a small subgroup of patients who are not currently classified through the PD-L1 test may now be considered for immune therapy outside clinical trials. The second big area of development in triple-negative breast cancer is antibody-drug conjugates. And there's just a list of the different targets that are currently being investigated in triple-negative breast cancer, including LIF1A, including TROP2 with 2 agents, including HER2 or HER3. Sacituzumab got recently approved in Europe, and prior to that was approved in the US based on the result of the ASCENT trial that showed substantial improvement of progression-free survival compared to standard chemotherapy, but also overall survival. But most importantly, for me personally, most impressively, I should say, we see a substantial increase in the objective response rate from 5% with standard chemotherapy to 35% with sacituzumab. Now, we learned in the last 12 months, we had some biomarker data focusing on TROP2 expression, and we learned that the higher the TROP2 expression is, the higher response rates are. But even in patients with low TROP2 expression, we still see superior efficacy compared to standard chemotherapy in terms of response rates, but also in terms of overall survival. We saw in San Antonio this year updated result of a phase 2 trial with TROP2, with a TROP2 targeted ADC, Dato-DXd, and that shows again in a heavily pretreated group of patients, substantial single-agent activity with nearly 50% responses of patients who are naive in terms of prior sacituzumab or prior DXd therapy. But also highlighted here in orange and yellow, it does show that a second TROP2 targeting ADC, Dato-DXd, can provide benefit if patients had received prior treatment with sacituzumab, which targets the same target, or if they had pre-treatment with the same payload, DXd, with a different ADC. And that raises important considerations around resistance to ADCs, sequential therapies, whether we'd see resistance against target or payload, and how we assess this. The safety profile has been very manageable. The drug is currently moving into phase 3 trials. We see also in the last 12 months the emergence of what I would call a new therapeutic subtype of breast cancer in triple-negative and in ER-positive disease classified as HER2 low. I would call this a therapeutic but not biological subtype, as HER2 clearly is not the oncogenic driver in those patients. If we reflect on how to become up with HER2 positive versus HER2 negative disease, this was always around the benefit from trastuzumab therapy. And therefore, patients who did not show a benefit from trastuzumab therapy were classified as HER2 negative, even if they were IHC 1+ or 2+. But we've seen now that in this group of patients who have low HER2 expression, if you use a different HER2 targeted agent, if you use ADCs, and in particular, if you use T-DXd, we can see substantial single-agent anti-tumor activity, objective response rates in IHC 1+, 2+ patients of 37%. And we learned over the last 12 months that about 2 out of 3 patients with ER-positive disease and 1 out of 3 patients with triple-negative disease are classified as HER2 low. There's also interesting data presented by the French group here at San Antonio, showing that even in patients who are HER2 zero on the last biopsy, there may be a benefit of T-DXd therapy. How is this possible? Because the T-DXd is targeting HER2. One of the possible explanations is that low HER2 status can change and can be heterogeneous, as we see on the study on the right side. So in summary, HER2 is an interesting emerging therapeutic but not biological subtypes, and I look forward to seeing the phase 3 data with T-DXd and other new ADCs in this setting. We're also trying to expand the use of ADCs and combining them, for example, with immune checkpoint inhibitors. As you can see here, subset analysis of the Begonia trial, combination of T-DXd, HER2 targeting in HER2 low patients, triple negative patients, and durvalumab, immune checkpoint inhibitor, showing a response rate of 66% in an untreated group of patients. That's very encouraging and warrants further investigation. So where are we with triple negative breast cancer, and where do I think our challenges are in the next 12 to 18 months? We clearly have to revisit the role of immune therapy, post-immune therapy in the early triple negative breast cancer setting. We will have to do quite a bit of work on working out how best to sequence those ADCs and whether or not we should combine them, for example, with immune checkpoint inhibitors. And we're expecting interesting data with AKT inhibitors and DNA damage repair targeting drugs. If you look at ER-positive breast cancer, finally, we'll see the standard of care is clearly now CDK4/6 inhibitors in the first-line setting, maybe with aromatase inhibitors or fulvestrant, depending on whether the tumors show hormone sensitivity or not. We have seen in the last 12 months data on overall survival, not just updates in the second-line setting, but most importantly now also first-line data with Mona Lisa. And we see emerging data around the somatic mutations associated with resistance to CDK4/6 inhibitor and a first therapeutic strategy around this from the PADA-1 trial. In the second and third line setting, we are obviously looking for new agents to overcome endocrine resistance. All SERDs have probably been most in focus in the last 2 or 3 years. And we have the first phase 3 data with Emerald. I will also share some data with CDK7 and HDAC inhibitors with you. Going back to the overall survival data, we had already seen overall survival data in combination with fulvestrant, had updates this year of 2 of those 3 trials, again providing a consistent benefit with CDK4/6 inhibitors in combination with fulvestrant in terms of overall survival. Hazard ratio is around 0.7, 0.75 in those trials, and seems to be consistent whether patients receive endocrine therapy early on or had endocrine naive, endocrine sensitive, or endocrine resistant disease. Of interest is a subgroup analysis from the PALOMA-3 trial that suggests that patients who had prior chemotherapy for metastatic disease may have less of a benefit. If this is verified in other trials, it clearly raises important questions and emphasizes the fact that we should give hormone therapy and CDK4/6 inhibitors as early as possible in patients with metastatic ER-positive breast cancer. We've finally seen overall survival data in the first-line setting now as well with aromatase inhibitor. Mona Lisa trial reported data of AI with and without CDK4/6 inhibitor, extending overall survival clearly with a median overall survival of 63 months compared to 51 months, so 12 months benefit, hazard ratio of 0.76. And the benefit seems to be increasing year by year, as you can see in the lower half of the slide. On the right side, you can see that the benefit is relatively consistent across all subgroups. And ultimately, these data provide further evidence that our standard of care in the first-line setting should be CDK4/6 inhibitors. What happens after CDK4/6 inhibitors? What drives resistance? We have interesting data, mutational data, and patients prior and post CDK4/6 inhibitor. And you're seeing green is post CDK4/6 inhibitor. Some of those mutations are more common, in particular mutations around the estrogen receptor, ESR1 mutations, but also ESR1 fusion changes. We also see with chromosome 12q15, a new group of a cluster upcoming where possibly MDM2 inhibitors may provide a clinical benefit once those drugs will move into the clinic. For me, one of the highlights of the last year has been the PADA-1 trial, French academic trial, patients with first-line endocrine therapy, aromatase inhibitors, and palbociclib underwent regular cfDNA analysis looking for possibly emerging mutations in the ESR1 gene. There was, of course, a number of patients who had disease progression without an emerging ESR1 mutation, but what the trial really focused on was those patients who did not have disease progression, but where over time an ESR1 clone was coming up. And the hypothesis here was if this clone is coming up, probably disease progression is not far around the corner because the aromatase inhibitor therapy is probably inadequate in those patients. So these patients were randomized to continuation of their treatment with aromatase inhibitors, which would be the standard because those patients did not have progressive disease, or early switch to a third compound with fulvestrant, which should have better activity in patients with ESR1 mutations. And as we can see very impressively, this doubles progression-free survival from 6 to 12 months with a hazard ratio of 0.6. And this is not just down to the use of fulvestrant as a second drug, because if those patients who had finally disease progression on aromatase inhibitors were switched to fulvestrant, it only worked for about 3.5 months. So this is a really intriguing, very elegant study that suggests for me we should look into this and possibly adjust our treatment strategies if patients have emerging ESR1 mutations. A big focus over the last few years has been on the development of oral SERDs, and as you can see, there's a number of trials currently in phase 3 studies, but there are also other mechanisms of actions that are being explored, SERCA, SERAM, PROTAC agents. We've seen a number of early phase studies reporting out over the last 12 to 18 months, and all of them showed promising activity in small cohorts of patients, objective responses, good clinical benefit rates, but of course it's very difficult and actually impossible to compare those agents between the different trials, as these are small trials with different criteria. What all of those trials share is the fact that we've seen activity post ESR1 mutations, and that is really where one of the key indications for these agents may lie. We've finally seen the first phase 3 trial with the Emerald trial reporting out in patients in a second and third line setting with prior CDK4/6 inhibitor therapy, randomizing elacestrant, the oral SERD, against aromatase inhibitors or fulvestrant as investigator choice. Stratification marker was ESR1 mutations prior fulvestrant use, and the trial looked at progression-free survival in all patients, but also in patients with ESR1 mutations. Now, the trial is important from a mechanistic point of view, from a proof of principle point of view, because it clearly shows that an oral SERD has higher activity compared to aromatase inhibitor or fulvestrant, with a hazard ratio of 0.7 in the overall population and a hazard ratio of 0.55 in patients with ESR1 mutations. However, it is also clear that in these patients with heavily pretreated and hormone refractory tumors, single agent hormone therapy is not the optimal strategy. The median PFS with the oral SERD 2.8, 3.8 months is still very, very small. But as long as we have established the principle, it will now allow us to better select patients who may benefit from oral SERD therapy going forward. Finally, very briefly, focus on 2 of the new targets, or not quite so new targets, for endocrine resistance modification. One is HDAC inhibitors, and we saw a year ago data with entinostat in the E2112 trial with 600 patients, where the addition of entinostat to exemestane did not lead to an improvement in PFS and overall survival. We have now seen a slightly smaller study, predominantly conducted in China, similar design on paper, but the study populations may be slightly different depending on availability of other agents and pre-treatment. But patients were randomized to exemestane and entinostat or exemestane and placebo, and this trial does show a benefit in progression-free survival, hazard ratio 0.74, and also a trend in overall survival, although not statistically significant at this time point. So it's difficult to know what to make of those data. We need to understand why some patients respond and others don't, but it may be worthwhile to pursue these agents a little bit further, as there's clearly, at least in one of those trials, a signal. The second compound I want to briefly mention is CDK7 inhibitors. Again, CDK7 has been shown to be involved in resistance to hormone therapies by phosphorylating estrogen receptor and co-regulatory proteins, but also to CDK4/6 inhibitors where it can phosphorylate CDK4 or CDK6. There's a new orally available selective inhibitor of CDK7, which was investigated in a small study in patients with prior CDK4/6 inhibitor therapy and showed encouraging shrinkage and duration of response, and it's certainly worthwhile to be further investigated. So if I summarize the data of this year, in HER2-positive disease, clearly the highlight was T-DXd versus T-DM1, establishing a T-DXd as a new standard of care in a second-line setting prior to T-DM1, based on a hazard ratio of 0.28 in progression-free survival. The new ADCs and TKIs emerging, but we need to see what value they have post-T-DXd. Triple-negative breast cancer, we now have overall survival data for KEYNOTE-355, which allows us to use a second immune checkpoint inhibitor in PD-1 positive patients, but also considering different chemotherapy backbones. We see increasing data in triple-negative breast cancer with different ADCs, sagotumab the front runner at the moment, but encouraging data with T-DXd and Data-DXd alone and in combination with immune therapy are emerging. HER2-low disease is an emerging therapeutic, but not biological subtype, and I will hope that we will see positive phase 3 data here with HER2 target agents in the next 12 to 18 months. In ER-positive disease, we have further evidence that CDK4/6 inhibitors can substantially improve outcome, now improving overall survival also in a first-line setting. We are understanding increasingly the mutational profiles of tumors that are developing resistance to CDK4/6 inhibitors and can consider a possible switch of the endocrine backbone to fulvestrant in case of emerging ESR1 mutations. Oral SERD compounds have demonstrated now in a phase 3 trial superior efficacy in PFS compared to AIs or fulvestrant, but we'll need to work out where is the best use for those compounds. Maybe they have to move relatively quickly into early disease setting. There remains a high need for new targets to overcome endocrine resistance. HDAC inhibitors are being investigated. CDK7 inhibitors show early promising results. I would like to thank all the authors of the work I quoted today for sharing their presentations, their slides with me. I would like to thank everyone who helped to contribute to the success and look forward to discussing the new advances in a year's time. Thank you very much.